I haven't.
It's already. Is Tommy over here?
Yeah, he's right there.
He's here.
Him and Dr. Kruger are here.
And Dr. Kruger is here. So, okay. Why don't you put it up? Thank you, sir. Listen. Good morning. Welcome to the Department of Medicine Grand Rounds. Every Thursday before Grand Rounds, I take the opportunity to remind you and the opportunity to celebrate the lives of people who came many years before us, historical figures who, one way or another, have changed our lives for the very nature of the lives they lived or what they contributed to our understanding of medicine, of being a doctor, of the human body, of education, of humanity. And today it gives me great honor to remember and celebrate someone who lived history and shared history with us here in Louisville and who passed away just a few weeks ago. You all know him. Dr. Jeffrey Peter Hersig obtained his MD in 1967 from Case Western, Ohio. He underwent internship and residency training at the same institution until 1969, and then went on to do hematology oncology training at Washington University after a short stint at the National Cancer Institute. He returned to Washington University in 1975, and there he remained throughout most of his career as assistant, associate professor, professor of medicine, and beloved educator and scholar at Washington University. I met Dr. Hersig in 1987 when I was a fellow. I'm sure many years later when I met him here, he didn't remember me, but he had such a strong reputation at Washington University that I did remember Dr. Hersig. He later went to sunny Buffalo. He did a stint in hospitals in New York, but we were lucky enough to have him here in 2000, where he joined the James Brown Cancer Center to assist his brother Roger in the care of very ill patients with bone marrow transplantation, leukemia, and several other hematologic disorders. He was an educator, a researcher, a scholar that had over 100 publications, primary publications, over 30 articles, wrote a lot and did a lot of work in clinical trials in the area of leukemia, and is well thought in the country and around the world for his work in that area. And most importantly, his students, his peers, our faculty, and the hundreds of patients who really owe their life to this man will always remember Dr. Jeffrey Hersig. I thought about writing a few words of my own to honor him, but I really felt there was nothing I could say that would do great justice. So I'm going to leave you with some words before we introduce our speaker of the day, some words that I stole from Robert Ingersoll. The record of a generous life runs like a vine around the memory of our dead, and every sweet unselfish act is now a perfumed flower. The loved and loving brother, husband, father, friend, died where manhood's morning almost touches noon, and while the shadows still were falling toward the west. He had not passed on life's highway the stone that marks the highest point, but being weary for a moment, he lay down by the wayside, and using his burden for a pillow, fell into that dreamless sleep that kisses down his eyelids still. While yet in love with life, enraptured with the world, he passed to silence and pathetic dust. This brave and tender man, in every storm of life, was oak and rock, but in the sunshine he was vine and flower. He was the friend of all heroic souls. He climbed the heights and left the superstitions far below, while on his forehead fell the golden dawning of the grander day. Speech cannot contain our love. There is no gentler, stronger man. I now leave you Christine Kruger, the Division Chief for GI, who's going to introduce our guest.
Good morning. So I'm sure Dr. Herzig was also very happy because he did what he loved every day of his life. I'm going to introduce to you again Dr. Thomas Abell, who's been here not less than 2 years. And I won't go through telling you that he came from Vermilion, South Dakota, and has practiced at Yale and Memphis and Mississippi and on and on and on. Because now what I want to tell you is people come from all over the country to have treatment by him, and I want you to know what he's done in less than 2 years here. He has a waiting list of 492 patients from yesterday's statistics, again from all over the country, and the fellows and faculty have seen at Jewish Hospital, where his motility center is, patients who do indeed come from all over who say, wow, I had chronic nausea for 12 years and now I don't, and my life is back again, because that's one of the most debilitating illnesses you'll ever have. Tom has also involved more than half of our 14 fellows in his innovative research and has published no less than 30 articles and abstracts since being here in the last year and a half, and tells me he's a bit behind on his publications. Without further ado, I'd like to bring Tom up here so that he can tell you about gastric electrical stimulation.
Thank you. Hope you can hear me with my southern South Dakota accent. Let me know if you can't. I'm mic'd up twice here. So, interestingly, growing up in South Dakota, even though my family was from Kentucky, so I would come back here in the warmth in the winter, but in January, it never got above zero the whole month. So it was like last week every day, and it wasn't until later I realized you didn't have to live that way. So I'm going to talk a little bit about stimulation, and I'm going to try to make it stimulating and large. And I've got a lot of slides to go through. Some of it, motility is very visual, so some of it I'm going to go through slides rapidly, sort of like the early days of motion pictures. I've got my disclosures, which I've updated with the Abell and NIH, but the same as before. The only thing is that the intellectual property I had before in Mississippi now is in a Kentucky company per the instructions of the transfer office here. So we're going to talk about the history of electrical stimulation and talk for a few minutes actually about history, because one of the things I love about Grand Rounds is it talks about history of science, which is two of my main interests. I'm going to focus on two things, gastric and obesity, and some talks about mechanism, which preparation for a symposium we're having in Orlando in March on mechanisms of electrical stimulation, which will be for all therapies, and then talk about some future uses. So a case presentation. This is a 56-year-old female that I saw actually last spring with diabetes for 26 years. She had a previous gastric bypass and lost 200 pounds. She had chronic nausea vomiting for 2 years. She lives between New York and Florida. Actually, very nice lady, but a little bit different lifestyle than probably the rest of us have. But she commutes between the two and has a couple of homes. Seen all over the U.S. Told that gastric stim was not an option, and actually came here from a well-known clinic in the Northland, where she'd been the week before, where they told her it wasn't an option. She wanted another opinion. So the GI symptoms were primarily vomiting on a scale of 0 to 4, none to worst. And her emptying of solids had 43% retention. It should be less than 10% at 4 hours. Electrogastrography, which I won't dwell on, was abnormal. And we scheduled her 2 days later, actually, for a temporary stimulator with a couple leads in her gastric pouch, and sent her on her way back to the hotel with a daily symptom diary. Day 5, the vomiting score was 0. And her emptying had improved in 3 or 4 days of stimulation from 43% to 27%. Cutaneous electrogastrography had changed slightly. And she was wanting to get a permanent device, which she got. In the OR, she had, as I'll show you briefly, had a good response to electrical stimulation, and at 1 month had no vomiting. At 6 months, we saw her, she had some episodic vomiting and turned up her device. And when I talked to her 2 days ago, she only has a vomiting score of 1. She has an occasional vomiting spell, but really is back functioning and just moved to another house. So I'm going to go back 505 years to 1509, and just a little bit of personal history for my family. Henry VIII came into power in 1509, and one of my namesakes, Thomas Abell, was young then, and later went to Oxford and wrote a book called Invicta Veritas, opposing Henry VIII, which was not a smart thing to do. He ended up in the Tower of London in 1532, and I was there recently and got this picture. This is his engraving, Thomas Abell. He got out the next year, but unfortunately would not be quiet, and was put in again, and actually was executed in 1540. So I'm thankful that I'm here today and I can say what I want without worrying about being imprisoned or executed. But within 100 years, not surprisingly, my family had left England and came to Maryland for 150 years, and then Kentucky. So we go now to 1809, and there's a couple Kentucky connections here. One is that Lincoln, of course, was born in Kentucky, and Darwin and Lincoln, as you may know, were born on the same day, February 12th, 1809. Interestingly, Darwin's book was published right around the time Lincoln was president. But Ephraim McDowell, another interesting man, did his first successful abdominal surgery on Christmas Day, 1809. And as some of you may know, the medical center named after him. He was born in Virginia. His father was the first surveyor of Kentucky. He was married to the daughter of the governor of Kentucky. Went to Scotland, where he studied medicine, and came back. And actually, when he operated on the lady in 1809, her anesthesia was singing hymns. She sang hymns while he operated on her. She survived, and he later treated James Polk, one of his patients. So he was an interesting man. But if we go ahead 100 years, in 1909, you see the background of electrical stimulation. Three Nobel Prizes that are involved with this. One was Pavlov's in 1904 for integrative physiology, and he was very interested in motility. Golgi and Cajal won the Nobel Prize in 1906 for neuroanatomy, and we still look at the Cajal cells. Actually, Hippenbach in 1913, JAMA published that you could stimulate the colon with basically a car battery. And Walter Alvarez, I'll talk about later, went to Boston in 1915 from San Francisco to study with Walter Cannon, later published electrogastrography. So these are the three giants. But interestingly, if you go on NobelPrize.org, which I did recently, they have the acceptance speeches there, and what they're talking about is exactly what we're talking about today in terms of neurophysiology. I mean, these guys have figured it out. Continuing on, the electrogastrogram was adapted from Einthoven's original work with EKGs, and it's still much confusion about it, but less controversial as we do direct measures, as I'll talk about. Some more history. Earl Bakken, who's co-founder of Medtronic, is still alive actually in his 80s. He worked with Dr. Lillehei at the University of Minnesota and developed these external boxes, which was the first cardiac stimulators. And he actually developed a GI stimulator called Peristart that I talked to him about a few years ago when he was still able to travel. And he worked with a young surgeon named Michael DeBakey, actually. And they were trying to work on post-op ileus. This is 1959. Eventually gave that up and was dropped as a product, but was on the market for a while. There's some more Minnesota connections. Walter Alvarez later moved to Mayo Clinic, and his son, actually, Lewis, won the Nobel Prize in Physics. And his son and grandson actually came up with the discovery of the meteor that hit the Earth and caused the extinction of the dinosaurs. But Alvarez set up a program where people like Charlie Code, who was just retiring when I was a fellow, and Carlson worked with Keith Kelly, who was one of my mentors, a very physiologically based surgeon, and developed a small bowel stimulator to improve absorption in the 1960s. And that was the animal model that actually we used in the 1980s in Memphis. The original use of neurostimulation goes back to the article in Science in 65 by Melzack and Wall. And there had been another Nobel Prize in the meantime by Abell and Lowy in 1936, which was a Nobel Prize on neurotransmitters. So people had begun to realize something was happening. And this article on millisecond wall is attributed to the rise of TENS, which everybody's heard about. But TENS led to development of deep brain stimulation, which was approved in the US in 97, cerebral stimulation in 97, gastric in 2000. And actually, the work I'll show you that we did in Memphis was done at the same time without us knowing about it. The people in Europe worked on these. Peripheral stimulation has been used extensively now. There's a whole international stimulation society. Esophageal stimulation is now about to enter the U.S. for reflux by one of my colleagues who worked with me for a year. Pharyngeal stimulation for sleep apnea was in the New England Journal last year and actually put together by, in the last week on sleep apnea, put together by people I used to work with in Minnesota. And that will probably be approved this year. And now obesity, which I'll talk about later, is the next frontier. So the clinical use for GI electrical stimulation has primarily been gastric, which I'll talk about in some more detail. But there's been two competing approaches. One is high energy, much like cardiac, and one is low energy, which is what I worked on. And basically first used in humans in '92, and then there was a series of investigations that led to its approval. The scenario for device development is to me, is very interesting, and it goes back to the whole idea of science and history. And you get an idea and a technology, and then it's applied, and if it works, then you get new ideas, new technology, new applications. And as I'll show you in a minute, all those approvals for stimulation all basically use the same kind of device. All of it all came out of the 1965 article in Science. So this is actually, I usually try not to show tray beams, but it's the only one available slide. It's the only one on the market. But this is the same one that's going to be used for sleep apnea, the same one that's used for thalamic stimulation for Parkinson's, the same one that's used for sacral stimulation. And it's really a 1960s, 1970s design. See if I can. Okay. So who benefits from stimulation? Are patients different from others? They have similar symptoms. Many have systemic problems. Some of you see patients that I see, you realize that they're tolerant quite well. But one of the main issues has been psychological factors and the presence in GI patients. And my own background was, in 1969, was in New Haven, Connecticut, was the assumption that these were all psychosomatic. And I spent a year in South America, on my way to South America, and I was on various places looking for these proof of these theories. Of course, they were based on supposition and probably weren't true. So I spent a number of years in vain, but hopefully not totally. So I have the three crazies, and it's sort of like I was watching TV the other night. They have the crazy ones. It's on. You may have seen. This is the three crazies that could make a pitch for a sitcom, I guess. But the myths that have become over the years are the patients are all crazy, the tests are crazy, and the doctors must be crazy to take care of the patients. And I deal with these, not so much here, but still with the insurance companies every day. The fact is the patients may be distressed but are chronically ill, and their psychological profiles are identical to other chronically ill patients. Secondly, the tests are based on established physiology. And the third is that the NIH actually consortium was created because the NIH realized that there are patients out there that were suffering. And much like the fatty liver consortium that came about by patient demand. And they're dedicated MDs, just like in every specialty. So I'd like to show one of the attempts to try to look at this, the three crazies idea, and that was a study that we just had on January 25th in JAMA on tryptolene in idiopathic gastroparesis. And I know this study well. We screened close to 2,000 patients, and actually my group in Mississippi screened about 600 of those. There were 130 randomized, 40 of them were my patients. But we did a sub-analysis, and our patients were no different in Mississippi than in the other 8 centers. And they were randomized very, very appropriately in the consort diagram here. And you'll see, although there were some trends, early satiety approached significance. Basically, it was a negative study, And tricyclics, at least it's done in this study, are not useful for gastroparesis. And I think the reason for that is if you go back 20 years ago and look at our first study back when we were working with prokinetics, and some of the patients were failing and going to J-tubes, and we started to look and see why, and that's because most of them have anatomic problems. This is a young woman with quote IBS. It's a trichrome stain, and she has a classic change of scleroderma with no external manifestations, and involves her muscle here and nerve here. And likewise, here's a young Church of Christ minister, a patient of mine with episodic vomiting. And he had normal electrical rhythm for a while in the OR, and then he goes into these episodes, which would be called VTAC. It was the heart, but it's GTAC. So these people have neuromuscular abnormalities, and that's why close to 100% of them, by the time we see them, don't get better. So what measurement tools can we use? Do we have a Google Glasses for motility? Well, newer is not always better, but it's best if you have new tools to be hypothesis driven, and so we develop new hypotheses. And I think the cost of technology, which are not cheap, as you know, although hospitals may be the primary driver of costs, I think technology in hospitals is behind that. And so I think value is going to be the newest criteria for payment, as we all aware as we go into the affordable and unaffordable era. This is the, talking about GI, electrical stimulation, talking about gastric. This is the current technique that we use, putting electrodes either temporarily in the mucosa or externally on the outside of the body antral junction. This is what the device that's used in every major therapy now looks like. A circuitry here, a battery, which may last from 2 to 10 years, and a connector block and a suture. Relatively difficult technology, but some patients benefit and some don't. The question is, who are those that benefit? So our first patient we did in Tennessee in 1992, January 92, 22 years ago, excuse me, was a diabetic patient, pancreas transplant. Mother was a malpractice attorney, father was an anesthesia physician. And in the hospital for a year, opioid dependent, not an ideal patient, but she had a peg for feeding and venting. We put a fetal scalp lead in there, and she got better. We got FDA exemption and IRB approval for one case, and then they said, well, it's good it works, but now you've got to write a protocol and do the studies. So in our approach to the studies, we had already heard about this man, who I've gotten to know at least through emails, Michael Rollins, who I later realized was Sir Michael Rollins. He founded NICE. He was a pharmacologist in Newcastle for many years, and he was the founder of NICE until retiring a little over a year ago. He's now head of the British Medical Society. But he wrote what I think is the best article. I've talked about this before. At the end of January, there's a joint issue of Lancet, December, January 2008-2009. And he talked about evidence, which is evidence-based medicine, which is primarily the Mendelian model. He talked about observation, which is the Darwinian model, which I showed Darwin. And talked about mathematical, which is the Einsteinian model. And basically, he says we can't afford to bankrupt us. We got to primarily rely on observation, which is what most of medicine has been. So an interesting article from the guy who was the forefront of evidence-based medicine. They all have advantages. So studies for gastric stimulation I've talked about before. They're controlled, they're double-blind, randomized, open-label case reports. But we did a series of trials, all of which I was involved with, and some of which I was able to come up with the names for. Some names were better than others, but that's been an interesting 20 years. But I'll show you just in rapid sequence of the evidence-based. This is Cochrane database from the UK. On the side here, this is better on one side, bad on the other. This is a series of studies. Most of them have the first name of me because it's A. But it's vomiting, nausea, TPN, and gastric emptying. There's only one that approaches borderline, which is one study here. Everything else is positive. So it's so positive, why is it not better accepted, particularly when the quality of life improves? And that's I think, because of a couple of issues that I'll talk about. But this is also survival, diabetics who get the device, diabetics who don't get the device. So it affects not only quality of life but survival, the two things that probably are most important. So perhaps the difference, biggest difficulty, I think, is mechanism, and that's why not just for gastric stimulation, but for all stimulation, the International Neurostim Society is having a symposium in Orlando in March to talk about this. And I think to try to understand the mechanisms here, you have to look at other devices, particularly thalamic stimulation, because of the animal models that we used for that are closer to humans, but also look at new technologies. So a few minutes on that. This is the way we currently do our test stimulation by putting an electrode in the enteric nervous system. And although we look at this endoscopically and say, gee, that's mucosa, we're also looking at the outside of the enteric nervous system with more nerves than in the whole central nervous system. So there's a gateway here. We attach it here. We sort of say there's Sirius satellite, DirecTV, and Dish right there. They can get good reception to use these. And we do about 2 a week. Here's a randomized study, which I did 10 years ago. 30 patients off on first, 30 on off first, except for the ones where the leads came out. In our previous technology, that was a problem. Everybody finished. This is what you see at 3 days, and why we do it. That's in 3 to 4 days. There's a dramatic difference between off versus on. What we didn't realize was how powerful the remodeling was. It happens in about 12 hours. And so even though we turned it off, it doesn't go back to baseline. And so this we see not really different. Also, this group is physiologically different than that, even though they're randomized. So we didn't realize, number one, you can't do crossover studies. And number two, you should randomize them physiologically. We looked at long-term data. Actually, one of our fellows and I just submitted this to ASGE. Looked at long-term data for 4 years post-temporary stim, and there's a good correlation. Interestingly, it's not as good for vomiting, and that's because so many of the people are zero here. It's hard to have a good correlation when zero is on the y-axis. But so it predicts pretty well. So what are the mechanisms? The 3 mechanisms that we've taught conceptually are either central, autonomic, or enteric, and I'm going to talk about those 3 mechanisms. And then after I talk about those, I'll talk more about obesity. So the central effect has conflicting data. Some people say that there's paraventricular excitability. Other studies, particularly in Europe, say look at visceral sensitivity and central excitability and say there's no change with electrical stimulation. It's hard to imagine there's no effect because I move my finger and there's something in the brain that shows. So is it cause or effect? Secondly, or autonomics, there's 2 ways to measure autonomics. One is systemic testing, which I'll talk more about with obesity. The other is cardiac autonomic testing with heart rate variability. And again, there's similar effects, but is it chicken, egg, or omelet? I'll show you some changes. This is people at 1 year. This is work we did in the 90s. In Memphis, symptoms get better, cholinergics go up, and sympathetics are a little change in EGG. And if you look, this is data from Little Rock, my brief stay in Little Rock, symptoms get better. And low frequency, which is sympathetic, versus over high frequency, which is cholinergic, changes. So there's a change there, and that's a very nice approach. We recently looked I was talking about this with patients here in the last year, people who got better than 50% improvement, less than 50%, realized that the patients, if they're even 10% better, they're happy. But we're interested in the group that gets better, greater than 50% in red here. And basically, not much change in vagal, but the people that get better actually are somewhat impaired in their posture and their spinal reflex. And they're also somewhat impaired in the electrical activity of the stomach. So it looks like actually if you're impaired autonomically and enterically, you might do a little better with the stimulator. We'll see if that turns out long term. So the enteric effects are what we've studied the most by our group, and there's 2 ways to look at that: gastric emptying and physiology. And I'd like to talk briefly about emptying and then about physiology. Gastric emptying is not perfect. It's much better than barium that we used to use because we don't eat barium, and barium has a sensitivity of about 5% for gastric emptying. 4-hour test is more useful. Back up here a second. 4-hour test is more useful. And what's important is percent retention, even though it's emptying test, quote unquote, it's retention. And delayed emptying is related clearly to Cahal cell density back to Ramon Cahal. The lower your Cahals are, the more you delayed your emptying. But liquids are important too, and we recommend now solid and liquid if possible. And it's important to remember that a number of our patients are actually rapid emptiers. So if they say the emptying test was normal, that may not be normal. You have to actually look at the numbers and see if it was done correctly. So here's about 8 years ago, 207 patients, vomiting, total symptom score, quality of life all improved, and their 1, 2, and 4-hour emptyings. A lot of it relates to Cahal cells and relates to how much energy you want to give, but emptying does improve with stimulation, contrary to what the literature generally says. What about electrical activity, which has been my interest for years? And logically, electrical abnormalities are going to precede mechanical abnormalities, just like in the heart. So let's look at the animal and human models for electrical stimulation. This is the smooth muscle in the gut is very similar to the heart. There is a absolute and relative refractory areas, and we try to stimulate in the relative areas. The stimulation we use is low energy, high pulse frequencies, and it's the same stimulation that was discovered for thalamic and spinal and will be used for sleep apnea, and they're all basically the same ideas. So these are implantable pulse stimulators. Here's early work. It's not a particularly good slide, but it was the best I had 25 years ago in our dog lab, which we had for 5 years. These are serosal electrodes. We turn the IPG on, and suddenly you get a change, first a slowing and then a rapidly increasing electrical activity. When you turn it off, it slows down again. Very similar to the heart. So you can affect electrical activity. And what we found was the higher we went on we call it pacing frequency, the higher our motility index, which led to our high frequency, low energy approach that we use today. We didn't have very sophisticated graphics then, but we were using contour plots here. Here are various frequency harmonics, and here's the turning the IPG on. You see this shift, which you can see a little bit better in a 3D plot. You see the shift when you turn it on. So you do something immediately when you turn on electrical stimulation enterically. Well, what about with humans? What about this patient? We did 2 of these yesterday. We mapped in a distal stomach and the proximal stomach. This patient has a G-tube as well. And you get electrical recordings, which you record routinely. What happens to those patients at 5 days, like the lady that I talked about earlier? Well, in general, the slope of symptoms is here. We had a couple of patients that got worse, but only 2 out of about 50-some. And I want you to remember that slope of that line, and you look at what happens to electrical activity, and the slope is the same slope. So I think it's hard to argue that they're not probably related. Likewise, in the operating room, which we do usually on Mondays, we implant these electrodes and we give low, medium, high energy, just like the cardiologists do. It takes about 15 minutes to give energy and do these recordings. This is from a talk last year at DDW. Here's, we've done a lot of these. This is patient ID 534, so we're up to like patient 900 now. But this is their electrical activity before energy, and here's electrical activity after energy. There's another patient before and after. So you can actually gastrovert the stomach in the operating room, and we use that as a basis for all the separate device. But what happens long term is the remodeling that seems to happen in 12 hours, and it can happen in minutes in the operating room, 12 hours mucosally. What happens? Well, this is from a talk at SAT a couple of years ago. The baseline frequency was 5, and the replacement basically 4 years was 3, almost normal. P-value was highly significant. And this is the replacement frequency versus the change in frequency. It's a very nice slope. R squared is 0.33. So again, I think the remodeling persists. And we see this in the heart. We see this in probably the brain and spinal cord as well. Here's somebody baseline electrical activity disordered and replacement of the generator, which is when we get the chance to record again, is here. So further investigation relates to new technology, and this has revolutionized things in the last year. We're lucky that we've been part of it, but high-resolution mapping has been used for some time, originally in the heart with these mesh arrays when I was working in Maastricht and the Netherlands. People were doing this in the heart. Later it was adapted in the uterus, and as you may know, uterine dysrhythmias are actually the main cause for premature labor, which in terms of the health care burden of premature labor in the world is billions of dollars because of the costs of premature babies. And so, although there's not yet a good way to treat uteruses, a lot of the emphasis was on that. We looked at 24 patients, and I realized I made an interesting typo. It's an elate emptying, which is similar to delate emptying, but minus the D. Half our patients had delayed, half non-delayed, and we did mapping upper, mid, lower stomach. We published the first half of them, the delayed half, in Gastro last year. The other half will be passed this year, and we're beginning to analyze their data for stimulation. It's a very complex thing. This is a pig model. It's a pig stomach. And here's the normal electrical activity of the pig right here. Here's if you give a burst of high energy stimulation, it really disrupts the electrical activity by turning it on in the pig. And in humans, this is requires a laparotomy and about an extra hour of time. We now have a laparoscopic wand that can be used that we've got IRB approval here. We've not used it yet, but we have it here. We can do this through the laparoscope or through a mini laparotomy. And what you see is just like a heart. Here's a normal electrogram, 256 electrodes, 0.4 centimeters apart, 4 millimeters apart. This is arbitrarily red as the beginning and blue as the end. And you see these velocity propagations. With our patients, this is here in the mid-stomach, you get these velocities. You get abnormal velocities when you measure them. You also get conduction blocks. You just come down and stop between the interim. And you also get re-entry phenomenon. Instead of the red coming here down to blue, the red starts here and re-entry. So it's just like the heart. And there's intense investigation, particularly in Israel now. There are a variety of companies that are trying to develop ways to electrically sense and gastrovert the stomach. So we'll see with that. Someone can text me in the nursing home if they've done it. So another technique that I'll just talk about briefly, but we just got funded for this by the NIH, which we're lucky we were the only clinical funding out of something like 80 applications, looking at confocal microscopy of biopsies, and it's already been shown to be useful for the University of Minnesota in diabetic neuropathy. And this would we wouldn't have to do for biopsies. These are pilot data, normal controls, hepatic diabetics, and post-surgicals having decreased numbers. So we'll see how that study goes. So far we've talked about restorative use of gastric stimulation, people that are nauseated, trying to get them to feel better. But what about disruptive use, for example, obesity? And let me show you the energies we're talking about. This is a relative energy we use when we turn up the device. The fellows are very good here. They take the device and go to the bedside and turn it up and bring it back and turn it out. So we turn it up, but it's all still in this framework down here. Here's the charge per pulse, the microcoulombs per pulse. Here's low energy, here's high energy, here's super high energy. But this is what's on the market. This is what's being investigated. We look at some other parameters. This is energy per pulse, low and high energy, and this is average power, which probably means the most, low energy and high energy. And it's literally, we've interrupted the scale. It's literally 10,000 times the energy for obesity than for gastric stem. So it requires a device that has to be recharged frequently through the skin. And I'm going to talk for about 5 minutes or so on obesity, which has been an interest of mine long before I worked on the other extreme, which was my NIH project was on anorexia nervosa. But we looked at central autonomic enteric components, and I'm going to talk about its relationship to stimulation. Classically, for autonomics, there's vagal cholinergic and sympathetic adrenergic. And sympathetic adrenergic's been abnormal in obesity. There have been several New England Journal articles on that. Vagal stimulation, interestingly, being used right now with a company called Enteromedics. But what do the studies show about it? Here's our autonomic lab in Memphis. Sympathetic measure here, cholinergic loss, enteric here. And this is normal reflex relaxation to ice. What I showed was abnormal in our patients that get stimulation is here. This is somebody with diabetes who actually vasodilates. So this is every pulse. You can also use postural adjustment ratio, which is hand up and down. This is abnormal in migraine and also abnormal in obesity. The enteric nerves are less well studied. Obesity actually is associated with rapid emptying. One of the original articles actually is from Louisville here in like 1970. And so the question is, will disrupting gastric emptying help? I'm going to show 3 studies that I've been involved with for the last 25 years, Memphis, Baton Rouge, and Louisville. First, for Memphis, we started in 1988, and I've had IRB approval continuously, which I still have, actually, for 39 obese patients undergoing vertical banded gastroplasty, which was the treatment of choice at the time. Baseline autonomic enteric data, we sequentially analyzed it, and it's getting a little hard to reach the patients now at 25 years. But there were 39 patients, mostly female, relatively young. We found our most useful data at 15 years. I'll show you that data presented with SSCI in Atlanta, the 1 year it was in Atlanta after the hurricane. And we had these energy cholinergic measures. Based on that, there were 29 people that actually lost and 10 that gained, and that usually was evident by 2 years. So this took a long time. And we wanted to see if we could separate by baseline measures into who was going to be a gainer, who's a loser, or a loser who's a gainer. But and basically you could predict by a discriminant model weight loss in 83% of the losers and 80% of the gainers, and correctly about 82%. And in retrospect, you could see that as early as 3 months. You could see what's going to happen. So when we get and you get this kind of a mathematical model with just 4 parameters, 2 sympathetics, cholinergic and enteric, and various coefficients. In Baton Rouge, where my former statistician is at the Pennington Center, which is the largest basic science obesity center in the world. We've been doing a clinical trial that I've been involved with for about 5 years, low-calorie diet, lap band, sleeve, and Roux-en-Y bypass, and look baseline 2 months basically, and 1 year, and then later. It's a very extremely detailed study. Hasn't been published because of the basic science will be published first. But I can show you, at a couple years ago, we already knew from small numbers that there was a variety of weight loss here, 4%, 16% at 8 weeks. But we also knew that we could predict autonomically, baseline autonomics, what their weight loss was, which was very intriguing. We now looked at it recently, and Neil Crittenden helped me look at this with Guy Brockman and statisticians here. And here's the low-calorie diet he lost at 7 weeks, but didn't lose it in a year. Interesting, you'll see some baseline differences here. Gastric sleeve is very big in Louisiana. This is not a randomized trial. It's full randomized. The sleeves lost the most weight, the bypass the next, and the band at least. And we also then constructed a model looking at the combination of baseline versus week 7 data. And when you do that, you see very similar. Nobody can predict baseline actual weight loss here, predicted weight loss here, which is intriguing because no one's ever found a way to predict weight loss. So we'll see. We also looked at electrogastrogram, which interestingly was the thing that changed the most at 7 weeks. Adjusted R-squared was 0.71. The p-value approached significance, and I'll show you that data. I only have basically low-calorie diet, sleeve, and band because there weren't enough to analyze the bypass. But basically, with the sleeve, which is quite disruptive for the upper stomach, you get a big spike at 7 weeks in AGG. It kind of comes down at a year. Band, you see it's change at 7 weeks, doesn't change in a year, and there's really no change in this. So that's one of our next challenges is going to be try looking at this. The data here in Louisville, excuse me, is our Excelis trial, which is a high energy GES, remember 10,000 times the energy. And it's a safety study only. maybe some hints of efficacy. There were FDA only allowed 20 patients worldwide, half in the U.S., half in Europe. And as you may know, the FDA now will take European data. The European data is done at the Maastricht, where I used to work in Netherlands. And we got our quota of 2 here in Louisville. The patients have been wonderful. And I'll talk a little bit about it. Very early, there's 2 months. Late spring, we'll have 6-month data worldwide and 1-year data in the fall. So we'll be able to make a decision. But so far, patients are doing well. And we also doing our autonomic and enteric models. So we'll be able to try to predict, even though our N is very small. So we'll know about the next phase. So what about the future of GES? I think for GIS, low energy has many possible uses. Cyclic vomiting, which we've already actually just submitting for publication. Atypical disorders, which I see a lot. Midgut, small bowel disorders, which I see a lot. The Swedish folks use stimulation for pseudo-obstruction routinely. G reflux is my former colleague. His company is already actively doing trials in Europe, and we'll start in the U.S. Hyperemesis I have some limited experience with. I'd like to show some data on malignancy-associated cancer-related nausea vomiting, which is an interest of mine. I was interested in this for many years, and then my brother developed pancreatic cancer and died within 8 weeks at age 48. And I literally watched him die vomiting, so I was even more motivated. And so I've studied a number of patients with malignancy-associated gastroparesis, which is a real disorder. I mean, it's got its own subheading on UpToDate if you want to look it up. Primarily defined at MD Anderson, but here's 6 patients, and I'll just show up this together. Here's, you see by the first 5 days, actually 3 of the first 5 days, you get a total elimination of vomiting. And then here's the long-term result in these 5 patients, nausea and total symptom score. So what we're trying to look at is, this is the next frontier, particularly for a wireless device, which we already have an animal model for. As you may know, over half the cancer patients die vomiting. And it's a major problem for refractory patients with chemotherapy and other post-cancer surgical disorders. Other uses may include pancreatic biliary disorders, constipation, and pelvic floor syndromes, and then high energy, which I talked about earlier, for obesity and for those patients with refractory to low energy. I'd like to show some previous work that Brian Barley's been working with me and writing up. It's just the same pig model that we used before for electrical stimulation, trying to see if we can stimulate duodenum and sphincter voting by gastric stimulation. And we used low and high energy. I presented this at ASGE last year. And interestingly, you do get some change in the frequency amplitude ratio. Whether this will have clinical applications unknown because we don't have funding to look at this yet, but we'll see if we get a wireless device. It could also be implanted for people with pancreatic biliary disorders. And it is known that chronic pancreatitis that's associated with gastroparesis, a subset of chronic pancreatitis, you can normalize pancreatic function with stimulation, which we published about 10 years ago in Pancreas. So in summary, and I'm going to hopefully end on time, GI electrical stimulation can be used for a variety of upper and lower conditions. And as I tried to point out, the background for this goes back scientifically and in terms of scientific thought a long time, and is being used widely in many other areas. The mechanisms, however, is not well defined or accepted, but there's evidence for central, evidence for autonomic and enteric. And new technologies, I hope, can help us understand the mechanisms, and new uses continue to be defined. The ultimate test will be demonstrated value. If you talk to anybody in the United Kingdom, everything is based on value. Is the money spent going to be worth it? So that's going to be the ultimate test. And I'd like to thank the staff at Tennessee, Arkansas, Mississippi, and particularly here, our motility clinic at Jewish that's been wonderful, our residents and fellows that have helped tremendously, the funding sources, of course, and lastly, our patients. Thank you.
Thank you, Tom. I have two questions for you. One more general and one related directly to your presentation. So many faculty, junior faculty and trainees often ask me, how do you decide to do this or that? There are gastroenterologists who focus on the liver. There are cardiologists who focus on congestive heart failure, and the pulmonologists who focus on asthma. What took you to motility?
What took me to motility actually
Get to the microphone.
was I was interested in cyclic nausea vomiting. It's probably a migraine variant. I had a family of people with migraine, so I'd seen this all my life, and I was sure it was psychosomatic. That's why I spent at least 5 years with that hypothesis, and it was a total failure. So
you had a family member who you didn't believe was really sick.
No, I knew they were sick.
Okay.
But yeah.
Okay.
So yeah, interest in nausea vomiting, and interest. What really got me in research was interest in mechanisms. I mean, it's that which is the essence of.
So not everybody knows how to do this. So you went into medical school, and did you find a mentor that actually said, well, come here. This is what I do. How did you? Many people come in already knowing what they want to do, but they don't find the environment that actually allows them to do that. They end up doing something else. How did this proceed from that interest?
I think three things. I had the scholarly interest in Haven about scholarship, even though that they sent me on totally the wrong track, which I never failed to tell them.
Never go to New Haven.
Yeah. And number two, you can go, but they may be wrong. Okay. Number two, when I was at Ohio State, I was a resident in primary care at Ohio State, but it was very much like Louisville. There were all kinds of people doing exciting things. I worked in the CRC, I worked in the sleep lab, actually, at Ohio State. And it was in the sleep lab that I got the idea, gee, you could do this in GI. So, and then when I was in Rochester, Minnesota, I was able to work in the NIH Course Center there. So I was able to get trained in research. So it's really those three things.
So it's actually in the sleep lab that you got said. Another evidence that pulmonary medicine drives a lot of specialties. So now going back to your presentation. So I was very intrigued. A picture is more than 1,000 words. And your picture about a GI tract and another GI tract where the fibers, that beautiful color picture where you have fibers that are normal and the other one that is totally distorted. So I guess you mentioned the word remodeling multiple times. But you were mainly discussing the fact that after a number of hours, the effect of the stimulator changes. Right. Tell me about this remodeling process, and why does it occur so quickly, and how do you address that?
Well, I mean, nobody understands about neural tissue, but that's why we're having this symposium in Orlando, is to try to look at that. It's real clear it happens, and it seems to be, it's true in the thalamus. The model there is a primate model. And thalamic stimulation that happens in the spinal cord and happens in the gut. Nobody knows why neural tissue does it. Clearly does that.
So is the term remodeling what you're saying is it desensitization of the nerve tissue to trigger the conduction, or how do you use that term?
Well, I think that's probably the current thinking. Yeah, I'm going to learn a lot in Orlando, I'm sure, because there's going to be a lot of this.
Okay.
So it'll be available online. So.
Questions? Yes, sir.
In the community, a common phenomenon is diabetics get abdominal discomfort, go through a number of medicines, and unfortunately a small group of them end up on narcotics, and then later get gastroparesis studies and decisions about this. How valid are those studies on narcotics, and how does the prior lengthy use of narcotics affect decisions and outcomes in stimulators?
Well, no one knows for sure. I think, interestingly, narcotics have very different effects in the body. And it doesn't affect the stomach as much as the colon. The colon always slows down. The stomach depends on the receptor. That's a very natural history that we see, and we see these patients all the time. And that's one reason we want to look at these mucosal biopsies with confocal microscopy to see if we can predict those changes early on. And that's why I think the NIH decided to fund that. We also found in a study that we published in the American Surgeon, it's published here, published this spring, looked at response to pain from stimulation, and you actually get an improvement in pain with stimulation. So the thought is that you get some beneficial effect from neural stimulation on pain. But diabetic neuropathy is a very complex disorder. We looked at that in the pancreas world. My former life was a pancreas transplant doc. And most of the neuropathies improve over time, but then maybe 2 to 10 years with pancreas transplant. versus kidney alone. And but the vascular complications, renal failure, don't improve. But the jury is still out on that, and we're hoping new technology like these mucosal stimulation, mucosal biopsies will enable us to answer that, because basically whenever you do an endoscopy, you could just do a biopsy and look at the neural regeneration of a patient, idiopathic or diabetic. So I don't know if that answers your question or not, but it's complex.
So gut flora seems to be associated with a lot of GI disorders in the gut flora. And have they looked at whether these individuals have alterations in their gut flora, whether this stimulator changes it?
Been unlooked at. In fact, it hasn't been looked at in GI motility at all. I've talked with Greg Plain about that regularly. You'd think that motility would look at that. The closest we've got to that is the FODMAP that some of you are familiar with. These FODMAP diets, which seem to help patients with IBS and also gastroparesis, these fermentable disaccharides. But that's a whole new world, and we're looking forward to that. It's called FODMAP, FODMAP. It's on the cover of Gastroenterology this month, actually, if you just Google it. And it's a diet that improves. It lists foods that have high in FODMAP and low in FODMAP, and we give it routinely to patients, and many patients get better. About 40% of our gastroparetic patients seem to get better with the diet. About 70% maybe of IBS patients.
You showed some slides about mapping and looking for foci where this abnormal electrical activity is coming from. In cardiology, we do very little overdrive pacing, or very little when an abnormality like the ones you showed, we ablate. So where is ablation in this kind of?
Ablation is just a thought at the moment. Yeah, that's what the Israelis are after, is a way to ablate. Yeah. The thing about Cajal cells are kind of like bone. There's remodeling that goes on all the time. Most of the damage appears to be inflammatory, and the other NIH grant that got funded the same cycle as mine was, or as ours was on how that damage occurs. It looks like it's probably a cyclooxygenase mechanism, at least in diabetes. So the thought is you have drugs that interfere with that damage, you won't get the damage, but we'll see.
Questions?
With regards to obesity, are there symptoms that are correlated with your ability to predict on gastromotility, like is hunger or self-distress, folks as to why they're going to either respond to weight loss or not?
Yeah, I can't tell you from this study, although we're looking at the symptoms, we don't have the data yet, but that's been looked at extensively.
And about predicting folks who are going to gain weight. So familial obesity and then looking younger to see what's going on in those stomachs ahead of time.
Yeah, the studies are in progress, but I don't have any data to tell you, unfortunately, yet.
You know, that question sort of reminds me a lot of your point that it's unclear the egg and the chicken kind of thing, or the omelet, which I like. This issue of does electrical stimulation change the brain to the point of altering these things? So I was going to ask you about vagotomy. Tell me the impact of vagotomy.
Well, interestingly, the vagotomy patients that get electrical stimulation for nausea and vomiting actually do better than the non-vagotomy patients.
Okay.
The post-surgical patients do almost as well as the diabetics. And the diabetics classically have an autovagotomy. Although the vagus nerve is primarily a sensory nerve more than a motor nerve, it's probably more than that. I think probably the sympathetics play a bigger role.
Well, a lot of that information, I mean, the vagus also sends back that information, so it certainly wouldn't be through the vagus that sends. So that's interesting. Well, thank you very much. I hope you have a good day.
Thank you so much.